And thank you from my behalf to the forum members and for the kind invitation to present. And it's always tough to come after Don and Parfit sort of from the academic perspective and really giving you some deep insight. So, you know, coming from the UN and from UNICEF, it's going to be very simple from my perspective. But I think really building upon what you've just heard, and there are going to be three key themes that I want to develop further. I'm going to go very quickly in terms of the progress, but really focus in on the theme of inequality. And I think this is essential as we think about not just allocation of scarce resources, but also the cost of inaction is much more profound in the poor and those who are already very, very vulnerable. But the flip side is that the rewards and the cost benefit and the cost effectiveness is that much higher when we reach those who need it the most. So I think what I'm going to do in my presentation is really sort of start to to make the bridge and move from the science and the biology, if you like, start to think about the issues of inequality, but then start to think about interventions and platforms for interventions, and leave you with some thoughts from my side, from UNICEF's programmatic perspective, or what are some of the opportunities as you deliberate upon the cost of inaction and the cost effectiveness of moving forward. So the good news, as Don said, is that we have made remarkable progress on child survival, that the declines have been real and widespread, as I'll show you in a minute. Basically, we've gone from over 12 million deaths in 1990 down to the last estimate for last year for 6.6 million. So in other words, 17,000 fewer children dying every year now than when we started the MDG estimates in 1990. And this is not just happening in Asia or in Europe or Latin America. It's happening across all regions of the world to some lesser or greater extent. But all regions have shown declines of above 50%. As WHO regions, the one that's lagging behind in particular is Western Central Africa, which is 40% decline, but relative to the other regions lower. But but widespread gains being made. And what's particularly heartening is that these gains are also being made. Some of the largest gains have been made in some of the most unpromising of settings when we started out. So countries which have shown actually have had, if not minus, but very little GDP per capita growth. Countries such as Malawi or Nepal or Tanzania or Liberia, Timor-Leste, countries which have had worsening socioeconomic performance in this period are showing reductions in mortality of over 70%. Quite a remarkable finding. And I think that's extremely relevant for our conversations here today as well, because not only does that mean that there's more children surviving, and therefore the potential for development is even more important, and the impact of development is even more profound, but it also suggests that there are things that have been done here, or platforms and approaches which we could learn from in terms of not just for survival interventions, but perhaps for more sustained development interventions, that we should be looking at how were the strategies, what were the strategies that were used in these countries to get critical interventions to women and children that is allowing these remarkable declines in mortality. And that's something I'll return to towards the end of my talk. But this progress does mask a number of inequalities. And the first one I want to touch upon is one that Parfit really talked about, which we quite often forget, is when we change from rates to numbers. So this graphic shows you the same sort of data on mortality, but in terms of numbers of children dying. In terms of numbers of children that are there. And so we are seeing an increase in population, but we're also seeing in countries which are showing a decline in the rate of mortality, the numbers of children actually increasing who die as well. So 39 countries, largely in Western Central Africa, the absolute number of children dying today is more than it was in 1990, even though the rates may have gone down. And that's because of our the laggard, if you like, in terms of reduction in fertility rates. And one of the key interventions which has been under-mentioned both today and in previous, in a more general child survival and development, is birth spacing. We know the studies around birth spacing are quite profound and convincing, and yet the unmet need for contraception and family planning in critical countries is as high as it's ever been. So the focus needs to be just as much on the empowerment of women and the supply and availability of critical interventions such as family planning, which will have that impact both on child survival but also on development. So one inequality we are seeing is the uneven progress across women and children. We are making good progress on vaccinations, thanks to the work of CDC in Rana and others in Gavi, but we're not seeing similar progress in other interventions, such as family planning, for example. This sort of story of uneven progress and development does manifest itself in countries quite profoundly, and quite often policymakers are not aware of these changes and differences. So I want to give one example that we've now been developing, and thanks to Claudia here and her team in UNICEF have really been at the forefront of helping us to look at how do we get across these inequalities that are not occurring just between countries but also within countries. So here's an example from the education sector of the average number of years of schooling. In Nigeria, an average is about 6.7 years of schooling that children have in there. But that in turn has socioeconomic differences. So the richest have 9.7 years versus 3.5 for the poorest. But even amongst the richest 20%, there is a difference between rural and urban, poor and rich as well. And even within those, there's a difference between boys and girls, in both the rich and the poor, urban and in rural. But you can even go further. In the rural context in particular, there are subgroups and large tribal and ethnic groups who have hardly any education at all. So in a country such as Nigeria, with an average of 6.7 years of education, there's a large population of rural Hausa girls, for example, who have barely any education at all. So it really is about digging deeper into the data that we have and presenting it in ways in which captures the attention of civil society and policymakers, which is going to be an important part of the progress that we need to make as we think about investments in social development, child development. The other inequality, if you like, is in where the progress has occurred. So and I'm presenting this in a sort of different way in terms of if we want to continue progress, where is it that we're going to have to make the biggest impacts? Where we have made the best progress has been on the childhood illnesses. So it's been on diarrhea, pneumonia, malaria, that we have managed to get the biggest gains. So on average now, countries, even in sub-Saharan Africa, are making 3 to 4% reductions in childhood mortality per year. But where we're not making the progress, and where if we're going to make further progress, is in the newborn and neonatal parts. And this is where, as you heard this morning, some of the most critical developmental issues also occurring. So the average gain globally, but in Africa for newborn mortality has been less than 1%. So it's been a completely different picture in terms of the mortality gains, a very uneven, once again, distribution of gains. But this is also where many of the developmental injuries and insults, which are quite critical in shaping future progress, is happening as well. So we're really going to have to, for many different reasons, put much more attention and focus on women and young and maternal and newborn than we have before now. So I want to shift a little bit to looking at those outcomes, to looking at some of the reasons and rationales of why this is happening. And there's no doubt that where we are seeing progress, the progress is being captured in many, many countries and many, many settings by the richest. This is just one example of reductions in stunting that we are starting to see in a country such as India, for example. But you can see the rate of reduction is much higher in the richest than it is in the poorest. We did some analysis a couple of years ago, looking at the 35 countries which have made the biggest progress in lower middle income countries, the biggest progress in reducing child mortality. And we found 23 of them, the gap between the rich and poor had widened as they'd made that progress. So in other words, the progress was being made predominantly by the better off and the wealthier in those countries. If you looked at the poorest in those countries, the mortality gains were actually quite marginal and much lower than that. An important reason for this is because, and this is work that the Countdown group and Cesar Victoria has leading, is access to critical interventions and critical services. And particularly for thinking about newborn and maternal and that critical developmental windows, if you like, we're seeing that the biggest inequalities that we see consistently across countries is for things such as skilled birth attendant, facility births, critical interventions in the early newborn period are the ones where we have the widest inequalities amongst all the interventions that we offer. But even universal interventions such as iodization of salt, and that was mentioned this morning as one of the most cost-effective and most important interventions we have socioeconomic differences. So this is an analysis of looking at the consumption of iodized salts in countries where they have universal iodization of salt, and you'll see that the proportion is not, if all children had equal access, it should be on this line, and most countries, it's the richest who have far greater access to even a universal fortification program, which has been extremely successful in terms of getting nearly all salt fortified, but still access and utilization is uneven because of the pricing and other issues to do with the cost of iodized salt versus non-iodized salt as well. So we must be careful and not just assume that when we have a universal intervention that the issues of inequality and equity are covered. So let me move on to then, if we accept this thesis that development, we have to be careful that the future investments are not being captured by those who already have and are already pretty well off, even in all settings, then we do need to think of the way in which we shape our interventions. And the earlier statistics where I told you about 23 out of 35 countries had widened inequalities, there are actually 12 countries which had narrowed inequalities while still making profound progress. And so when we looked at those countries to see, well, what is it that they did differently that they could still make remarkable progress but not at the expense of the poorest, one of the key differences was the strategies and the investments they made and the platform investments they made. And in particular, countries such as Malawi and Ethiopia and Nepal were investing quite heavily in community-based and locally relevant interventions, and one of them is community workers. And I'm sure many of you are much more familiar than I am in terms of the evidence and and now the latest guidance that we're now giving in terms of that community-based workers can have quite an important and profound impact on child development and stimulation, working both with caregivers and children themselves. And based on the work that Zorfi in particular has led, showing that relatively simple and straightforward interventions by not very highly trained women can have very significant and biologically and socially and psychologically significant impacts on women and children. So the challenge for us is to think about the platforms that we could strengthen, and this has quite important implications for the cost side of the interventions, which they don't have to be expensive building of build creches and formal facilities. I just want to give you a couple of examples. Here is a map of northern Nigeria where those Hausa girls live, for example, showing the distribution of community health workers that are employed by UNICEF. We have 8,000 community workers that we alone, just one agency, is employing in one of the poorest areas and the most deprived parts of the world. These are actually part of our polio investments that we're making. And if you look across the places where polio is still endemic, we have in total over 12, and this is a little bit out of date now, we have now 14,000 village health workers, community workers, who we alone, just as one agency for one program, are employing in 3 of the most deprived and important geographies where the deprivation and child development deprivations are profound. So there's already an infrastructure there. The other one that we're directly involved in is community case management, where we're now, once again, working with governments and donors to employ thousands of community workers who have been trained to treat and manage pneumonia and diarrhea and malaria. But there's once again the potential and an army, if you like, of workers who could be used for developmental and other interventions which have an impact on psychosocial development as well. I was just saying to Gary at the break, the Global Fund, malaria, $16 billion that they're going to be programming in the next 12 months. And a large part of that is going to be, at least a third of that is for malaria, which in turn, a large part of that will be around community case management of malaria. So as a community, we need to engage with those processes because they could potentially employ even more health community-based workers in these communities and pay for them. And so the additional marginal cost for us to come in with child development interventions, evidence-based child development interventions, will be very, much lower. And therefore the cost effectiveness and the cost of action will be much lower. So I just want to build upon what Don was saying in terms of the school platforms. There is here a very profound and widespread community platform, and one which could be even more strengthened, but it does require that as part of this process we identify those platforms as you go to countries and as you get inputs, and we think more creatively about making the connections across different sectors and different programs, even within the health sector. Thank you.
Thank you, Mikey. And last but not least, Maysoon Shahab from UNESCO.